Hello, everyone, and welcome back to Psychedelic Vantage. Today, I'm speaking with Sorcha O'Connor. Sorcha is a final year PhD candidate at Imperial College London, specializing in the neuroscience of mental health conditions. For her doctoral research, she led the PsilOCD study, which investigated a low to moderate 10 milligram dose of psilocybin for obsessive-compulsive disorder, or OCD. With a background in molecular and cognitive neuroscience, Sorcha focuses on understanding the mechanistic effects of treatments, an interest she channeled through PsilOCD by measuring psilocybin's impact on clinical symptoms, neuroplasticity, and cognitive performance. Following the study's promising results, she hopes to continue contributing to research into novel treatments after completing her PhD. Sorcha, welcome on the channel. How are you doing today?
Thanks for the great introduction. I'm doing great and really excited to be on here and to be talking about the results.
Yeah, I'm very excited as well. Really looking forward to learning more about your background, learning more about obsessive compulsive disorder, the current treatments that are available today, and the results seen in the PsilOCD study. To get things started, yeah, I'd just love to learn more about your background. What made you want to study neuroscience and enter the field of psychedelic research?
Yeah, so I've always been really passionate about biology. I was always set on studying something to do with that as a teenager. And then my interest in neuroscience grew mainly by being interested in mental health and things like human behavior. And I was able to study it from undergrad, so from age 18. And I mainly focused more on the molecular side of things during my undergrad. And I did a year abroad in Spain. That was an amazing year, and that focused on the epigenetic landscape of schizophrenia. But then I realized that my passion really lay more in doing cognitive neuroscience and, working with patients and techniques like EEG. And I was very lucky to be able to, after my master's in cognitive neuroscience, get this PhD at Imperial, which has looked at a very pivotal early stage study looking at psilocybin for OCD.
Yeah, no, thank you for sharing. And yeah, I'm really looking forward to learning more about these results. But before we look at the results, I think it could be helpful for the audience to learn more about OCD. What is OCD, the diagnostic criteria, and also the prevalence of this condition?
OCD is a very misunderstood condition and it's a lot more common than people think. So, going to the prevalence first, the lifetime incidence of OCD for people is around 1 to 2%,
Mhm.
meaning that that's the likelihood that you'll experience it at some point in your life in line with the DSM-5 criteria. And if you consider the OCD pattern, it's best described as an intolerance of uncertainty around one or more themes. So people will have obsessions and compulsions, and those are the two facets of it. And obsessions are thoughts, urges, or mental images around specific topics that the individual feels uncomfortable around.
Mhm.
And then the compulsions are things that they do to try and decrease their subjective levels of distress in response to them. And there are typically feared outcomes around their themes. So, for example, if someone's OCD centers around contamination, they might be concerned about being contaminated while eating and, ending up ill. They might have a worst case scenario outcome in their head of what could happen. And their compulsions could be cleaning everything they buy multiple times from the supermarket, or doing a lot of research online about types of foodborne illness, or even just calming themselves down in their head, because rumination and mental soothing are also forms of compulsions.
Okay, I see. And yeah, at what age can symptoms come up for people? Um,
People typically start to get symptoms while they're teenagers. It's typically around sort of 17 to 20, so sort of late teenage years, although around a quarter of people do develop symptoms earlier in childhood.
okay. Okay, thank you for that
Mhm.
background. And I guess when looking at mental health conditions, it's like very commonly stated that a lot of them are a combination, or the causes are a combination of biology, genetics, and also environmental factors. With like OCD, does it lean more towards one side than the other?
OCD is definitely a balance between environmental and genetic factors, like a lot of psychiatric conditions. there's rarely a satisfactory answer, but there are around 30 genes involved in neurotransmission, mainly the serotonin, glutamate, GABA systems involved, although there's no single gene that is to blame for OCD at all. And there's roughly a 50% concordance in OCD between identical twins, roughly, give or take. But then environmental factors play a huge role as well, with stress, especially during childhood and adolescence, playing a role, but also in adulthood. Some people develop OCD for the first time after giving birth, after experiencing illness, or the death of a loved one. It can cause them to maybe ritualize around a theme that perhaps hadn't seemed salient to them before.
And so first of all, you gave a great breakdown for us at the beginning with what OCD is. Could you maybe like give some examples of the types of intrusive thoughts people might have and what those compulsions could look like, while understanding it could look different for everyone?
Of course. So a lot of OCD themes lie mainly inside people's own minds, and they're not so much to do with external factors. There's a subtype of OCD that's well recognized online in forums and with people posting about it called harm OCD, where
Okay.
people will fear loss of control of their own mind basically, and they'll worry that they'll do something to hurt someone else or themselves. So they might start by thinking, what if I grabbed a knife and I accidentally stabbed someone? And because objects afford things to us in our environment, and everyone can have random fleeting thoughts, but with OCD this thought seems very viscerally real, and then the individual might start to ritualize around avoiding kitchens, avoiding being in the kitchen if there are children around, if there are knives, or they might avoid taking public transport and think, what if I push someone in front of the train? And that's a common way that subtype of OCD can manifest, and it's very debilitating. And these people are not more likely to do it, to commit these things, than anyone else. It's just fear based. So compulsions could look like avoidance in that case, or a lot of looking back to one's previous memories and thinking, last time I felt this way, did anything happen? But then failing to get that hit of certainty and then staying caught up in the cycle.
Yeah, that must be extremely difficult for people to deal with. Actually, when you were bringing up what you see online a lot, I actually was nodding my head because I thought you were going to say pure O. Is this
Oh, yes.
so? Can you maybe actually explain to the audience what this is referring to, and is it officially recognized as a subset of OCD?
Yeah, people do talk about pure O, and this was a notion that gained popularity maybe around 15, 20 years ago, that some subtypes of OCD are purely obsessional. And actually, this example that I gave of harm OCD would likely fall into that perceived category. People in the past would have thought, I'm not really performing any compulsions, I'm not, washing my hands, I'm not rearranging things. But nowadays, actually, well, it's been scientifically debunked, that idea, and most OCD researchers and clinicians don't really believe in it anymore, because the premise is that there are no compulsions, and it's now strongly believed that all forms of OCD involve compulsivity and people performing mental rituals and compulsions that they're not spotting.
Okay.
So that's kind of the big thing, is that a lot of compulsions, like I mentioned, are mental, looking like reassurance or even just thinking back to one's own memories. And they probably feel to someone with OCD like their best thinking, like normal analytical thinking.
Okay.
But they actually, alongside avoidance of triggers, they keep the pattern going.
Okay. I see. So in the present day, what are the current therapies and treatments available for OCD? And I think it could also be helpful to maybe go into what would be the first option someone goes to, the second, third, maybe fourth as well.
Yeah, so the first line treatment for OCD is exposure response prevention, or ERP, which is a type of cognitive behavioral therapy that gets them to confront their triggers, whether imaginally or in real life, and then not perform the compulsions, whether they be mental rituals or physical compulsions like hand washing, or checking that the stove hasn't been left on. The concept is that they expose themselves, feel the distress, feel the anxiety and discomfort, and don't actually try and assuage it in any way. And that's meant to test the brain's hypotheses that it's dangerous for them not to do the compulsions, by giving evidence that actually they can they can, withstand the unpleasant feelings and then nothing catastrophic happens. And the idea is the brain's priors will update a bit and place less salience around that theme. And it can be very, very successful. I'd say it's definitely the best way to treat OCD in terms of actually getting into the mechanisms and, the patient's specific hypotheses that they need to disprove. But it has a very high perceived emotional barrier of entry, with people really not wanting to partake in it. It's very uncomfortable at first. Even if it's done incrementally, it can be uncomfortable. So pharmacotherapy is really valuable as well in OCD,
Yeah.
with the main first line treatment being SSRIs or selective serotonin reuptake inhibitors,
Mhm.
because we actually don't have any OCD specific drugs.
So there's no drugs that like were specifically approved to treat OCD.
Exactly, yeah. There are no drugs that were designed and approved to treat OCD. So we give SSRIs as the first line treatment, and they're typically given at much higher doses than in depression. They're given sort of 2 to 3 times the dose of like sertraline, escitalopram, whichever it may be. And these can be effective, and they offer relief to around, well, not full relief, moderate relief to
Mhm.
around 40 to 60% of people. But
Okay.
then a lot are left treatment resistant actually to the first line treatments. So we then go into adjunctive pharmacotherapy,
Yeah.
and we'd start giving antipsychotics, particularly atypical ones like risperidone and aripiprazole off label. And some people even receive mood stabilizers like lamotrigine.
And I'd be curious to know is there any research looking into ECT, TMS, magnetic stimulation,
Yeah,
transcranial.
TMS is definitely gaining popularity, and it does offer comparable benefits to SSRIs, but probably greater in treatment-resistant patients, and it would be aimed at those people that have tried, ERP combined with SSRIs. But nothing really seems to be a silver bullet, with a lot of people slipping back into the cycle in OCD. And the same with ketamine therapy.
Mm.
It can have rapid effects, but a lot of people slip back into being equally symptomatic a few weeks later. So we're really looking for something that can move the needle a little bit in a more meaningful way and for a longer duration.
I think that gives us a perfect segue actually into psilocybin because I'm
It
sure
does.
obviously and I think our viewers know that what's very exciting about the research into psychedelic treatments is the potential of maybe 1 to 2 doses giving patients relief for a variety of mental health conditions out to months sometimes, which is very encouraging, maybe compared to ketamine or esketamine, where you're coming back on a weekly or bi-weekly basis.
Yeah.
So before, actually, no, this will get into PsilOCD. So what are the scales used to measure outcomes in OCD research and also in your study as well for PsilOCD?
Yeah, it's a good time to bring this up. So the main scale is the Y box, which is the Yale Brown obsessive compulsive scale. And it was created in 1989 by Goodman and colleagues at Yale. And it's pretty reliable, and it stood the test of time. It's still used in research and in clinical settings. And it assesses both obsessions and compulsions. So it has 2 parts to it. The total score you can get for both is 40, and then you split it into two. So 20 for obsessions, 20 for compulsions. And it also has an initial qualitative part that is the symptom checklist, and the clinician will just go through that with the patient and see what themes they relate the most to. And the goal of this stage is to identify, do they what vague, not vague, what broad themes do they identify with, like contamination, data, responsibility for others, or a combination, and what compulsions are they engaging in.
And from my knowledge, PsilOCD, it seems like looked at many different areas of OCD. I probably worded that wrong, but and maybe some of them were even more objective measures than subjective. Is that accurate to state? Like what else? Yeah, like what were you looking at in PsilOCD besides?
Yeah,
Because I know it was a lot more than that.
Yeah, it's definitely relevant to mention this, although it's beyond the scope of this episode because unfortunately these results are not out or that close to being out, but they should be in the next year. But the study was primarily mechanistic. So being an early stage feasibility study, it wasn't actually an official clinical trial. So symptoms, although they're, probably the most interesting outcome for the community and for a lot of listeners and people in psychedelics, are primary outcomes related to neuroplasticity, which we measured through EEG paradigms, stimulating the occipital cortex. And I won't go too much into that, but just seeing whether their capacity to form those memories is potentiated after the dose that we explored compared to placebo. And we also looked at different cognitive tests, two main ones that probe areas of cognition known to be affected in OCD. So there's actually an endophenotype or pre-existing trait where people with OCD are slightly impaired at this specific cognitive capacity called extra-dimensional set shifting. Sorry, it's attentional set shifting, but specifically the extra-dimensional component. And to put it simply, it just describes your ability to look at a type of stimulus, so maybe pink circles, and then to shift to something that's already in the frame, but that which wasn't previously important. So you might shift to looking at black lines that are also in the frame. And people with OCD are perfectly good at learning the rules in the individual dimensions, but they're worse at shifting between dimensions, and they tend to perseverate on the old rule. Okay. So we've also assessed psilocybin's effect on this, and a host of other things. We'll be sending off bloods for BDNF analysis, which will be interesting.
Brain 5 neurotropic factor?
Exactly.
Okay.
Yeah.
Okay.
Yeah.
No,
so we'll be looking more at the molecular basis of neuroplasticity that way as well. And then we also had some acute measures, which I also won't go into in this episode. They're still being analyzed, but we looked at things like, the mystical experience, challenging experience questionnaires, just relating to how the participant actually experienced the session.
Wow, it seems like it was very comprehensive.
It's very holistic, all different levels of analysis in the study.
That's really, really cool. So, when looking at the study, I thought it was super interesting to see the choice of using a 10 milligram dose of psilocybin as maybe the dose in the study that was thought to be most therapeutic compared to the active 1 milligram comparator. I guess the reason it was interesting for me is I guess this is a little silly to say in a sense, but after watching How to Change Your Mind on Netflix and learning about like the breakthrough experience that the
I remember that
had,
patient, yeah.
with OCD, it sounded like to me, of course this is one person, but it sounded to me like it was in a sense, I know we stay away from this word a lot, but it seemed somewhat curative for this person, at least for a long time. I think there's been follow-up interviews with this person years later, and he's still doing well. But anyways, yeah, it's one person. And so, yeah, I'm curious, why go with the 10 milligram dose in the study? I found to be very...
Yeah, this is true. There's definitely potential that a high dose could be effective in a condition as stubborn as OCD. But we chose a low to moderate 10 milligram dose compared to the typical 25 used in most depression trials in the past. And I believe at the Yale and Johns Hopkins studies on OCD at the moment, I think they're looking at 25 or comparable to that dose for OCD. But the reason we looked at 10 milligrams is because there's very limited research into psychedelics for OCD. And the only other formal study was conducted at the University of Arizona in 2006. And they looked at 3 doses. They looked at a very low one that was equated to around 6 milligrams per person, and then a moderate dose that was around 15, and then a higher dose that was closer to the classic 25 milligram dose. And they looked at 9 patients with OCD, and they found that all 3 doses were effective. Only at the 24-hour mark, though, they didn't do long follow-ups, but they found that there wasn't a dose effect, like a specific dose effect. So all 3 doses were comparably effective in terms of the statistics at least used. So that made us think that, if low to moderate doses, somewhere in between their 2 lower doses could be effective in OCD, that could give people, an option that isn't an intense psychedelic experience, and it might be a good time to look into that. And
Absolutely.
yeah, it's been
Yeah.
really interesting working with that dose because you do get a lot of questions.
So the first thing that actually came up into my mind when I learned about the 10 milligram dose in this study is, I guess, maybe the difference between psycholytic therapy and psychedelic assisted psychotherapy. So, from my knowledge, psycholytic therapy is more the European model with low doses of a psychedelic with a good amount of therapy actually in it, from my knowledge. And the psychedelic assisted therapy model with the macro doses being more the American model. Would you say that this study with the 10 milligram dose would you say it's similar at all to the psycholytic therapy?
This is an area I'm not that well versed in, but I do think that in around the 60s that the psycholytic model was more common in Europe. Is that what you mean by European, or do you mean modern day dosing regimens?
I think it was more like historically what had been used in
Yeah,
the 50s and 60s in Europe. I'm not actually 100%
yeah.
here.
Oh yeah, no, I'm pretty, yeah, I think that was the case. I think there was a German psychiatrist, wasn't there, who would do
I think that's
psycholytic. I'm not that well versed in that, but
okay.
it's interesting. But yeah, I guess we're working with a blend between the two really because we only gave one active dose.
Okay.
And as far as I'm aware, I think the psycholytic model would be quite a few more doses, probably around 10 doses, spaced apart by weeks.
Okay. I think that sounds right to me. Yeah.
I think it's kind of low and potentially even lower than 10 milligrams because ours was, it's a low dose, but it's by no means a microdose. It was, elicited gentle perceptual and emotional shifts that are actually quite profound for people. But yeah, I'm not aware of the therapy that was used in psycholytic models. It probably was more psychoanalytic, wasn't it, rather than
I believe so. I believe.
ERP or something. But it's interesting, and I think don't want to get ahead of myself before we talk about the results. But I think going forwards, it could be great to look at psilocybin for OCD alongside exposure therapy, maybe at a low dose. That does resemble this psycholytic model of tailored exposure protocols, maybe for 3 months or something, and the participant gets about 4 doses of a lower dose.
So would it be fair to call the study of the PsilOCD study fair that it was looking at psychedelic assisted psychotherapy, or were you really trying to isolate the drug effects to see what the drug does by itself as much as possible?
We definitely were aiming to isolate the drug effects,
Okay.
and our therapy was supportive but non-interventional.
Okay.
So participants didn't receive any OCD specific therapeutic intervention, which allowed us to look at, when they're well supported and when they have a good relationship with the therapist, but they're not receiving any specific intervention for OCD, does the drug have a therapeutic signal? A little bit like the early stage pharma studies as well.
Okay, cool. And yeah, I'd love to learn more. I think it'd be great for the viewers to learn more about um, well, the study design, like how many people, the dosing schedule, and of course, yeah, it'd be great to learn more about the results that we're seeing in the study.
Of course. It's great to be getting to this part. In terms of the study design, we set out to recruit up to 20 completers. That was always the goal. And in the end, we got 19 participants, except one individual had to drop out
Mhm.
before receiving the real dose due to unrelated circumstances in their own life. So we had 18 completers. So a fairly small sample size, but comparable to, a lot of research at this early stage.
And the dosing schedule, what did that look like? Like, how often was someone getting a dose of psilocybin?
The study was fixed order, so all participants received 2 doses. The first dose was the 1 milligram that you mentioned, the active placebo dose, and then 4 weeks later, they got the 10 milligram dose. And then we had a 4 week follow up after the 10 milligram dose. So this allowed us to disentangle the effects of both doses by having 4 weeks after each.
I see. And is it maybe an advantage when using the 1 milligram uh, dose to be able to tell participants, listen, you're getting an active dose with each session? Is
Yeah, definitely. And this is
okay.
this is one of the reasons, well, the main reason why we went for the 1 milligram rather than an inert placebo. because it allows you to, ethically, you can tell the participants on both dosing days you'll receive up to 10 milligrams. And this removes the risk of a disappointment effect. If they're told that one day will be a placebo that's fully inert, when they get into the dosing room, it's a very kind of ceremonial experience. They're there with both guides, and it's quite long as well. The whole day was around probably 10 hours with all the data collection too.
Wow.
And if they, 2 hours into the actual drug experience, they start to think this is the placebo day, or they realize quickly, you might get a nocebo effect. You might get people getting annoyed about the fact that they've taken the time out of their schedule, while having bad OCD symptoms, and then not actually getting anything. So by having 1 milligram, it allows their imagination to run a little bit, and maybe through some autosuggestion for people to feel like they've got higher, which actually was the case for that placebo day. Which I
Wow.
can talk about when we cover the results and then when we cover blinding.
Yeah, absolutely. I'm actually curious to know what type of music was used in this study. This is an area I think doesn't get discussed enough in the world of,
You're right. I never really hear this discussed on podcasts.
I
We
know.
used a playlist that was curated by psychedelic researchers at the University of Copenhagen. So Dia Stenbeck and Sophie Armand,
Oh, okay.
they curated a lovely 4-hour playlist that participants listened to during both the placebo and the active sessions. Both sessions were identical in terms of contextual factors to try and
Okay.
maintain blinding. And it was, it's quite Scandinavian inspired, like very, very nice to listen to. It starts off quite gently with some neoclassical pieces, and then it ramps up a little bit. There's a bit of a crescendo around the 1 to 2.5 hour mark, with some slightly shamanic influence, with, some slightly breathy vocals, faster
Okay.
tempo. And then it winds down a little bit, but very positively. So it definitely takes them on a journey that's, I'd say, maybe more classical than others that I've listened to, but I think the participants really liked it. We can even link it if people are interested in hearing, because
Oh, yeah.
it's public on Spotify. So if it inspires anyone else's research, or they just want a relaxing playlist to play.
Oh, that sounds great. That sounds great, actually. I am going to look into that, and I'll try to link it down below in the description. Um, Oh, yes, staying with the music. Sorry, this is always very interesting to me. Were there a lot of lyrics in the music, or when you were speaking about vocals, maybe it was just sounds rather than like complex?
Exactly, yeah. They're
Yeah.
more sounds. Yeah, yeah. We definitely stayed away from complex lyrics. I don't think there were any lyrics in any of the songs. I think
Okay.
that could definitely be some subliminal messaging or something that you wouldn't
Yeah.
really want.
I could definitely understand that. So yeah, in the study, so I understand that you were trying to isolate the effects of the drug as much as possible. With that being said, I'm sure safety was was very important for this study, and you all probably yeah, focused a lot on that. So like how many preparation sessions were there before each dose and post-dose sessions to check in?
So, yeah, participants received 2 preparation sessions before the first dose. And then after that dose, it was technically the post 1 milligram follow up phase. So then they had 3 integration sessions that were obviously, treated as if they'd had the full active dose. And the third and final integration session occurred one day before the real dose. So it was technically kind of like the final 4 week follow up for the 1 milligram, and also the 1 day pre 10 milligram preparation session, if that makes sense. So the therapist would talk about, how the participant felt 4 weeks after the dose, but also, even practicalities of how they felt about traveling into London the next day for the dosing study,
Yeah.
and how they, what their expectations were. So yeah, so 2 formal ones before the actual onset of dosing.
Okay, great. Thank you for that background. So yeah, now on to the results. Based on what you can share at the current moment, like what did you find in this study?
So first of all, to keep it as simple as possible, I'll share the results that are actually coming out in the clinical paper, which should be out imminently, which is so exciting. And this analysis is an ITT analysis, or intention to treat.
Okay.
And I won't necessarily go too much in. We can talk about that after if it's interesting or relevant, but basically it just includes all of the dropouts that you might have in a clinical study.
Okay.
And we, like I mentioned, we had one dropout who didn't drop out due to adverse events or side effects or anything, but who wanted to receive the real dose, but had to stop participating in the study before they were able to receive it. And so this is a very conservative approach, and it's common in psychiatry because technically, if you remove all the dropouts, you are almost cherry picking a little bit before your analyses.
Mm,
If people have received a drug daily, if they're taking sertraline every day and then 3 people drop out 4 weeks into a 2-month study,
okay.
and you remove them, you actually might be removing people that wouldn't have improved. So you are potentially skewing the results a bit more to be a bit stronger and a bit more positive than they might otherwise be. But this approach is very conservative in our situation because we only had, we had the one active dosing day, the 10
Mhm.
milligram, well, not active, the placebo was active, but the one experimental dose day. But we did this nonetheless because it's often, considered the most rigorous way of analyzing results in psychiatry. So, looking at the 19 participants, we see a significant dose specific effect,
Mm,
and we see a decrease in OCD symptoms on the whole, obsessions and compulsions, 1 week after the 10 milligram dose. But then, unfortunately, it then drops below significance at the 2 and 4 weeks.
mhm.
So that is the signal for the total Y box. It's
Cool.
symptoms are improved 1 week after the dose compared to the placebo, compared to the relative change elicited at that time point by the placebo dose, importantly. And we didn't see any effects on co-occurring depression scores, which I didn't mention that we
Oh,
also
okay.
measured because it's a common comorbidity.
Yeah.
So yeah, that's interesting. So we saw a therapeutic effect on total Y-box scores, nothing on depression, which was assessed via the MADRS scale. And then we looked specifically at the effects of the 10 milligrams on obsessions and compulsions.
Mhm.
And with this 19 participant analysis, we didn't see an effect for obsessions, but we did see one for compulsions at the 1 week mark. Although I'd be cautious to interpret this as, psilocybin treating compulsions but not obsessions,
Okay.
because I've also run analyses for my thesis and just out of interest on the completers because I felt like the analysis that we've run for the paper is great and very robust, but I think it's almost slightly eclipsing some of the significance because we did a last observed carried forward
Yes.
correction,
I
meaning
see.
that so the dropout who had to drop out was almost treated as if they stayed in the study and then their symptoms didn't change. So by nature, it's going to probably going to reduce the signal seen. But when I ran these analyses, I saw the significant effect for total Y box sustained to the 2 week mark. So we see
Wow.
it 1 week after 10 milligrams, and then we still see it at the 2 week mark, and then it drops beneath significance. Um, and we also don't see any depression changes. So that's
Okay.
quite reassuring to see. It's just quite interesting that it seems to act on the obsessive compulsive machinery and at this quite low dose and not really shift the mild to moderate depression symptoms that some of them had.
This actually, so thank you so much for sharing about this. I'm actually curious to ask with let's say someone has OCD and co-occurring depression. I guess is it the question like what came first, the chicken or the egg? Is it the do you think it's possible that people develop depression because of their OCD symptoms?
I think that's often the case. I mean, there are cases where people have severe depression, but the participants in our study didn't. It was mainly co-occurring and, it wasn't consistent. They didn't feel depressed every single day, but they mainly just felt demoralized because of their symptoms. And that can become very real. It can, get someone a score that's moderately depressed if they're assessed on a day that they feel lower. But yeah, I'd say there's definitely overlapping neurocircuitry with all of these psychiatric conditions, anxiety as well. Even trauma, makes depression more likely, makes anxiety more likely, and OCD as well. But in this instance, yeah, I think it's definitely a real phenomenon that for some people it's secondary to their OCD symptoms.
So, based on the results, I'd like to know from your perspective, were there any surprises? Were maybe some expectations met or not met in the study? And what can researchers learn from this from the results moving forward with psilocybin as a potential treatment for OCD?
I think we did hope that the results would be sustained for the whole duration of the follow-up period because it
Okay.
was a fairly short one. But we didn't really have a strict hypothesis around this. It was quite exploratory because, there's been very little research on this for OCD. In terms of surprises, I feel like, running the study was quite a smooth experience. It definitely involved a lot of work and took us about a year and a half to finish it, but we didn't really have there was nothing that made us think, we have to completely amend the protocol, we have to change the study
Okay.
during it necessarily. Um, and also, just one thing before we move past the results, it might be interesting to people if I talk about response rates, like a slightly
Oh,
different
absolutely.
angle of looking at them because we've just spoken in terms of statistics.
Absolutely.
So among the completers, we can also look at response rates based on how this is measured in OCD
Is that a
and a
50% reduction or more in symptoms, like response is considered for depression? I think, yeah.
is it 15 or
Oh,
50, did
no,
you say?
50, 50.
50, interesting. For OCD, a strong response is typically 35% or more in white box
Okay.
reduction.
Good to
So kind of
know.
comparable.
Yes.
And out of the completers, 7 achieved this reduction at the 1 week mark, and 4 out of the 18 maintained it at the 2 and 4 weeks. So that allows you to conceptualize a little bit better.
Cool.
Also, probably better than me saying statistics for such a small number of people. And we can also look at symptom transition. So we can consider, did they move down into a different category of the Y box? Because everyone that we recruited had at least a Y box score of 16, which is considered moderate OCD. And full remission is considered 7 or lower. So most people out of the general population will, who don't have OCD will get maybe Y box 6 or Y box 3
Okay.
because these symptoms do exist on an adaptive scale. Like it is, it's helpful for people to enact some type of checking behavior to overthink things occasionally. Um, but no individuals actually reached full remission. So no one dropped into the below 7 Y box point, but 10 people reached mild severity, which is considered 8 to 15 Y box at the 1 week mark. And then 7 out of the 18 people maintained this mild level of OCD at 2 weeks, and
Hmm.
then six of them at 4 weeks.
Oh,
So a
oh,
decent group of them have had, a significant amelioration in their symptoms that actually did last until the end of the
and
study.
and this is based on one low to moderate dose of psilocybin.
Exactly. Yeah,
Oh,
without any
that's
of the
very
exposure therapy.
Yeah, that's very interesting. I actually overheard you, not over, I listened to you in another podcast, mention with the choice of the dose, thinking, and it totally made sense to me that perhaps people with OCD, maybe due to rigid thought patterns, it might be difficult to let go into the experience, maybe. That,
Yeah,
you
this
know,
is yeah,
I'd be
this was also our
curious.
line of
Yeah.
thinking. Sorry, there's a tiny bit of a lag there. I'll let you finish.
Oh, no, sorry. What's it called? I'd be curious to know what are your thoughts on, and actually not even just for OCD, but for other conditions, like a study where I think actually Robin Carhart Harris in his study with treatment-resistant depression, I think they might have done this, where you start with a 10 milligram dose. Maybe you're more
Yeah.
acclimated to the experience, preparing 3 weeks later for a 25 milligram dose. Could you see that being an interesting area of research for OCD and also other mental health conditions as well?
Yeah, I think that's definitely something that could be appropriate. I mean, initially, as you mentioned, we did think about it from a safety perspective and also just from comfort, thinking that a lot of people with OCD don't enjoy loss of control or even the idea of loss of control because a lot of the themes center around how one might lose control or how one might not feel in control of their own thinking and actions. So we thought that, having a full 25 milligram experience might be too intense. But I do think from working with this group of participants, I mean, people were generally very happy during the psychedelic experience. I wasn't in with them, but the therapist reported it all to me, and the participants would share experiences with me, their experiences. And I think, yeah, when I think about all the individuals that took part in the study, I think most would be quite comfortable with that experience, having had the 10 milligram one. Although it is hard to tell, isn't it? it does really depend on the subtype of OCD, probably, because some types of OCD do mimic panic disorder type patterns a little bit more, especially somatic types where someone might be concerned about their heart rate and, focus on,
Okay. Yeah.
there's a theme called sensory motor OCD that's interesting. It's people end up focusing on a specific bodily process, something like blinking or breathing or their heart rate, and it becomes this seemingly intractable loop of focusing on it and then feeling like it's not working properly, and then lots of meta thinking involved. And I think it's, something like that could be escalated in a psychedelic experience and could be a bit traumatic potentially. But then at the same time, I think with, the therapists on either side of the bed and the patient reclining and listening to music, it might also be a great time for them to effectively, have some thoughts about that and expose themselves to them,
Uh,
and refrain from the compulsion. So I think it could be a great learning opportunity as well, subjecting people to a higher dose.
I see. No, that makes a lot of sense to me. And it's interesting that you mentioned that there were reports that the experience was pleasant. I think a lot of sometimes people in the psychedelics world think that an experience might sometimes have to be challenging to get good results. That's not a belief I subscribe to personally
Interesting.
in the present day, but that's very interesting to learn that it was a pleasant experience for participants and that there was some relief from symptoms from a low to moderate dose of psilocybin. Um,
Yeah, I mean, just to add, some people definitely did have some challenging experiences, and
okay,
things were brought up from their past
wow,
and
on
all of
10
that. But
milligrams.
yeah,
Okay,
definitely, people did even during the first 1 milligram dose, which
wow,
might also say
wow.
something about how well people with OCD can kind of be absorbed into that type of experience, and there might be more potential in working with, low doses in a psycholytic model for people who prefer that, and then having high doses for people who want to shift something more rigid. But yeah, people definitely reported quite emotional experiences. Some symbolic things as well. Sometimes family members appearing. Thinking back to conflicts and things with people.
Yeah.
So I definitely wouldn't say that they were all pleasant, but I guess I meant more to say
Okay.
that people weren't really worried about the actual subjective effects. We didn't really have we didn't have any experience where a participant wanted the drug experience to end or any kind of panic
Oh,
response during.
okay. Yeah, because I am aware that it seems like common with the common challenging experiences, people have the fear that they're going to stay in the mind state that they're in forever and
Yeah,
that they're dying as well and they're, so anyways, do other psychedelics have potential, do you think, to alleviate OCD symptoms?
I think other classic psychedelics do, and there are some case studies from, the 60s and 70s looking into LSD and it being effective in OCD. But those obviously worked with very small sample sizes and will need to see larger trials over the next few years. But yeah, I think LSD, has very similar actions on the serotonin system, and I think it could definitely be beneficial. Although some say it could be more stimulating, especially
Okay.
for people with a condition like OCD. This is maybe a strange point, but I do think, though, that there's something to be said for how natural and holistic psilocybin can seem to someone. And I know a lot of participants became really interested in different types of mushrooms and, felt like they were connecting with nature before the study. And, I think if people are erring towards being a bit more anxious of loss of, worried about losing control, that psilocybin might have the edge when it comes to actually just how we consider it, coming from a mushroom a little bit more purely than LSD comes from something natural. Um, but yeah, I think in terms of the pharmacological side of it, I think all classic psychedelics, 5-MeO, regular DMT, LSD could also definitely go into that main OCD circuitry.
Very cool. So speaking with someone like yourself who has a background in neuroscience, I've been looking forward to asking you this question. We have a lot of promising data, at least in rats, and mice so far, with non-hallucinogenic neuroplastogens. I guess drugs that stimulate the 5-HT2A receptor without the hallucinogenic effects. do you believe that these type of treatments would be, do they have a good shot, you think, at working in OCD, maybe?
I do think they could have potential actually after this study, especially given that we didn't actually give exposure therapy. And, it does seem to me that whilst the therapy was really beneficial and participants really enjoyed it, we were able to, remove that effect by removing the 1 milligram, and we saw the drug effect. So I do think non-hallucinogenic psychoplastogens could have potential, and they'd be given more regularly, wouldn't they? Almost like SSRIs for a period of time.
Hmm.
So I guess we'll need to advance with
Yeah.
with research to gauge that, to see that kind of feasibility of how often they'd be given. But I think, if they do go in there and activate 5-HT2A and similar receptors, I think I saw a company post about one that now acts on 5-HT1B as well.
Hmm. Yeah,
I think I saw that posted yesterday. But if they act on these serotonin receptors that classic psychedelics do, I don't see why they wouldn't be helpful, especially given we know that SSRIs act so broadly across the serotonin system, and that might be partially why they only have modest benefits in conditions like OCD. So it may be that we're actually coming across receptors that are better at getting the therapeutic flywheel going alongside therapy, just in classic
hmm.
psychedelics, and that non-hallucinogenic ones also, if they act at these receptors with similar affinity, I think, yeah, there could definitely be benefits. Although there is, of course, this idea that the mystical experience or even just subjective, emotional
Hmm.
upswing is a big part of it. And I think it probably is. And I mean, we've seen that it moderates clinical effects in depression, or there's been a study that looked into that. But it's too early to say whether that's required in OCD. It may be that OCD is almost more biological in terms of how it needs to be treated. Maybe we need to just get into the circuitry and then do therapy on top of that. Um, Whereas in depression, the mystical experience is more transformative, but it's a bit too early to tell.
It's really interesting when people speak about these non-hallucinogenic neuroplastogens having zero hallucinogenic effects, because I'm pretty sure there's been people who have ordered, somehow, maybe through the dark web, they've gotten hold of these non-hallucinogenic neuroplastogens, and
Okay,
they've reported that they're not hallucinating, but they're feeling different, and
interesting.
there may be some effects there. Maybe not full on hallucinations, but I think, yeah, I'm excited to learn more about these.
That's interesting. I need to read
Yeah.
about this. I haven't come
Oh,
across
I got to
that.
send you an article about it. It was fascinating. I think it was written
Please do, yeah.
by Shayla Love. Um, yeah, you got to remind. Maybe I'll even link it at the description. We could speak about it. Very
Yeah,
interesting.
I'd love
And
to.
you mentioned the dosing every day. I've also personally heard that some groups are looking at, yes, like daily, everyday dosing, and also maybe even the potential of non-hallucinogenic neuroplastogens to be taken like on a monthly basis. I've heard of that at
Oh,
least.
okay.
So
Interesting.
yeah,
Okay. I haven't heard about that. That's cool. So what, maybe at a higher dose, they would elicit a stronger increase in neuroplasticity and you wouldn't want to be giving it every day.
yeah, and there's also with these neuroplastogens, there's, I think, a ceiling effect to where they're thinking that no matter how much someone would be given, there still would be no hallucinogenic effects. But yeah, I've been, trying to learn a little bit more because I'm seeing so many groups now working on these non-hallucinogenic neuroplastogens, and I'm thinking, like, what's the difference between what this group's working on, that group? But anyways, yeah, no, it's I'm excited to see data from, maybe it'll be like a year and a half from now, see if it has any effects on depression. So Sorcha, first of all, thank you so much for coming on the channel. This was great, and congratulations on this study wrapping up. It's I think such a huge accomplishment, because I feel like, yeah, OCD has been neglected in psychedelic research, it seems. And it sounds like this study really, it was pretty groundbreaking, especially all the different measurements you were looking at. So congratulations. The
Thank you.
Yeah.
And thanks so much for having me on. Like I told you before, I've loved your podcast since I started watching it, and I always recommend it to people who want to get their heads around the psychedelic industry. So yeah, it's been
Yeah.
amazing to be a guest.
Thank you. That means a lot. So the final question I'd like to ask you is, based on the results seen in PsilOCD, along with maybe the few other studies that have looked into psilocybin as a treatment for OCD, do you think that there can be a future where psilocybin therapy can become an approved treatment for this condition?
I think we're still a little while off, but I definitely see a future where it could be given alongside exposure response prevention.
Okay.
Personally, I think that that will probably be required, and I don't think any pharmacological agent on its own is a silver bullet for OCD.
Okay.
Probably similarly to PTSD, where
Mm,
individuals in both conditions they're different in many ways, but they have to kind of get into specific hypotheses, things that their brain think are true about the world, are true about themselves, based on the past experiences they've had, and in OCD, just based on the neurobiological component of the condition that just goes ticking away and causing them to focus on different themes that appear salient to them at that moment. So I think personally, I think if someone comes in with contamination OCD, for example, they need to work alongside a therapist, or maybe even there'll be advanced ways that people can do it themselves. Identify the core fears or core issues and triggers around their themes. So, what do they actually think will happen? And learn to expose themselves to elements of that incrementally. Maybe imaginal exposure as well, imagining certain outcomes or imagining just even sitting with the discomfort before they sit with it, and then also doing real world exposures, especially if they have physical compulsions that they need to
mm,
refrain from doing, or physical situations they fear, maybe travel, public transport. They'll need to go into those environments, I believe, in order to actually transform the OCD themes that they deal with. But I think pharmacotherapy, like I've mentioned, it's already transformative for people, even though a lot of people are left treatment resistant, which sounds ironic, but it does offer a lot of people relief.
mm.
And half of our participants were on SSRIs actually,
Oh,
which I didn't mention.
did they have to be washed out before
They actually didn't. No, in line with some
they?
data from Compass that found that
That's,
being on SSRIs didn't actually dampen the therapeutic effects in depression. And we believe that ethically as well. I think it wouldn't have felt right to ask people to come off them because OCD can be so debilitating and so distressing. And we were also testing a fairly low dose of something
yes.
experimental. But yeah, going back to the idea of psilocybin, I think I see it as another tool to add into more precise, personalized exposure therapy that really allows people to focus on what they believe will go wrong if they don't perform their mental or physical compulsions.
I see. Sorcha, again, thank you so much. I'm really excited to put this one out.